Well, I would like to formally open the meeting. Welcome, everybody. My name is Richard Oudevossa. I'm a professor of geriatric psychiatry at the University of Groningen. And together with Kenneth Chambert and Radboud Marijnissen, we have founded the IAADM just to bring people together with interest in medical assistance in dying for people with mental disorders. From all over the world, whether or not it is legalized in your country or not, but just thinking about and learning about the ethical challenges, clinical challenges, etc. And I'm the treasurer of the foundation. And today we have our fourth meeting. It is the also means that we are now 1 year running, and we're very happy in this meeting that we have Professor Carla Coetzee as one of our speakers, and she's a professor of psychiatry at the University of Pretoria in South Africa. She has the geriatric psychiatry unit and is also a consultant psychiatrist and a forensic psychiatrist, and she's particularly interested in medical ethical issues, and she completed her PhD on the ethics and challenges in medical assistance in dying in people with severe mental illness, and as I thought especially the older people, isn't it? And I'm happy to give her the floor for her talk, and then afterwards we can have questions for her and have a discussion. And in the second part we have a clinical interview of Radboud by someone with, how do you say it, an expert in experience, but I will come to that later on. So Carla, floor is yours, and happy to for you to start.
Thank you. Let me just quickly share. Okay, so I hope everybody can hear and see clearly, but thank you very much for this opportunity. It's really a privilege to be part of this discussion today. I'm from South Africa, as you heard, where we really are far behind in updating our legislation around these issues. But, you know, these are very important things to consider if you look at the global picture about the changes that has been happening in many countries. So that is where I became very interested in this, and working as a geriatric psychiatrist, you know, it's obviously things that we sometimes encounter, and especially if you don't have the legislation to back you, then it can sometimes be quite challenging. But so today I will obviously then be speaking about specifically medical assistance in dying in patients with serious mental illnesses where there's no other terminal condition. I think in those instances it's different, and it's people feel that it's actually sometimes easier when there is a terminal condition present. And I think there's definitely more countries where legislation's in place for people to get assistance if they have a terminal condition. It's really this area where in the absence, but then just for the mental illness itself, where it becomes very, very challenging and complicated. So just some clarification about the end of life versus the psychiatric MAID. So end of life MAID is then specifically for people who have these terminal conditions. And as we know, you know, it's really more accessible in countries with much more expansive medical services, wealthier countries, and that is then basically allowing the person how they want to die, because they're already in the process of dying, but they can then ask for assistance if they feel that that will give them a more dignified death. Where in psychiatric MAID, it is then, like I mentioned, where it is really only for the mental illness, and it's due to the mental illness that they feel that they are suffering and they do not want to live anymore. So as you can imagine, this is a very, very vulnerable population. You know, with psychiatry, there is still a lot of stigma that's a problem, challenges with treatment, but I'll get to that a little bit later. But that is where we must then just make certain that certain protections are in place. So the thing is, with serious mental illness, we know that people have a shorter life expectancy. You know, they have a lot of non-communicable diseases that contributes to morbidity in these patients, you know, cardiovascular, other chronic long-term illnesses that really can contribute to their quality of life not being optimal. You know, despite maybe the mental illness being fairly well controlled, there can be these other things. So with the medical technologies, we can control a lot of things and we can prolong life, but in the end, there is the concern that we can also then prolong suffering in these cases. So we must really just be sure that we are not doing things to extend someone's life if it's really not in their best interest in the end. So in the psychiatric MAID, from the literature, what I've worked through, what people did find is that it's usually people who previously considered or even attempted suicide that will make these requests. And interesting is that it is much more frequently from females, from women. So there's a lot of things written about this, you know, where males will actually take matters into their own hands, where females will maybe rather make these requests for psychiatric assistance in dying. But, you know, it's not very clear why it is this predominant thing that it is so much more women who's asking for this. But the diagnosis of the people who has received assistance in dying, and these are obviously from a variety of countries, but mainly Luxembourg, Netherlands, Belgium, where these things are in place. But it includes autism spectrum disorders, eating disorders, where we know there is in any case a high chance of mortality if the patient does not get the necessary assistance. But then also other things like post-traumatic stress disorders, schizophrenia, personality disorders. And what I found quite interesting is even prolonged grief. Patients have received assistance with dying. So the thing is, if you consider the end of life assistance and then psychiatric MAID, there's differences. You know, obviously a patient with a psychiatric disorder like bipolar disorder, depressive disorder, or schizophrenia, they're not necessarily dying. You know, they might have a lot of comorbidities or poor quality of life, but it's not that the disorder itself will lead to their death, unless obviously if there is suicidal attempt or completed suicide. The thing is, the legal frameworks between different countries also vary, and there's definitely differences. So I'm not going to cover all the different legislation. I think that is just too extensive. But some of the common elements then will require that the condition must be unresponsive to treatment. Now, that is where one of the differences come in. Some countries will allow then, even if the patient refused any intervention, that will still be acceptable, where other countries might really insist on them actually going through a whole process, having certain interventions, and then, you know, even going for things like ECT or transcranial magnetic stimulation or other interventions if the medication does not help. The poor quality of life is usually a very strong consideration, and then the intolerable suffering. But those are really some of the commonalities. But like I said, there's quite a few differences in terms of the application, the requirements, evaluations that have to be done, and all those types of things. The thing is, what was interesting is that there's also now, it's just an article that I read about the proposal to implement a medical assistance in dying for people without any psychiatric diagnosis or necessarily any other medical problems, but who just feel that they have really reached the end of their life, that they just have lived enough, you know. So it's that sense of, or the concept of a completed life. So as far as I know, this is still not in place, but there's definitely some countries considering moving in this direction. And some of the motivations or the considerations that they mentioned for this is then things like loss of independence when you develop frailty, even though you might not have a terminal condition, but there can be loss of autonomy and self-control, social isolation, which I know is in our elderly population in South Africa a very big problem. So I'm sure it must be in other countries something to consider as well. But then just that fear of further decline, you know, if you are a fairly healthy older person who's lived a functional life, and now you've reached that stage where you feel that, you know, just continuing is not going to give you much benefit, and you are then scared of what the future might hold. The thing is, what makes these cases quite complex is because of these multiple geriatric syndromes that you get, where, you know, we know that these things can be very complex, multifactorial, but it can definitely lead to unbearable suffering in these patients, even in the absence of terminal conditions or a serious mental illness. But I think the sense that I got from the literature is that there's still quite a bit of reluctance from the medical side and from physicians to become involved with these types of requests. The thing with serious mental illness then specifically, one of the major aspects and the concerns is then always the decision-making capacity of the individual. So in people who have major depression, 20 to 31% of them, obviously there's variances in the literature, but that is specifically the estimate of how many of them might lack decision-making capacity, especially if they're in an acute remission or relapse, you know, if they are ill at the moment. And we must just always keep in mind that obviously these things change over time and that it's very, very specific to that decision that has to be made. So they might not be able to make decisions about treatment and care, but they can still decide about where they want to live, for example. So we must not always make these a blanket assessment. But surprisingly, in the literature, there's quite a lot of psychiatrists who think that just having a diagnosis like this, like major depressive disorder or schizophrenia, might already imply that there is impairment in your decision-making capacity. But I think we know that it's much more nuanced than that. And even though we should apply a systematic approach in these cases, where we use the 4 components, the understanding, reasoning, communication of the decision, and so on, it can sometimes be very difficult. And it's not a black and white assessment. It's more a gray area in many of these conditions, and obviously linked to the seriousness of the outcome of the decision that's being made. All those factors might play a role and have to be considered. So these are not easy assessments to be done. One thing that is definitely a very strong predictor of impairment in decision making is the insight of the patient. So anosognosia, we know if you don't even think that you have the illness, that can definitely contribute to an impairment in decision making capacity. But still, it's not a blanket. If you have that, you can't make a decision. It still has to be assessed for that very individual decision. And then obviously there is the respect for autonomy that always comes in. Now, there's a lot of criticism about the focus being too strongly on that, especially in some of the more individualistic societies and so on. But I think we know that we have to really look at a patient's autonomy. And we have to balance that with the other beneficence, the other requirements or ethical considerations. But we can't just disregard the patient's autonomy if we feel that it's going to be too much of an effort to really check their decision-making capacity. And that is in where I think sometimes people are just told that, no, you can't make this decision. This is what me as the doctor or the multidisciplinary team want. But I think we must be careful that we are not very paternalistic in those structures. So I'm going to summarize some of the arguments against and then for medical assistance in dying in the next two slides. So the first, we'll look at those against medical assistance in dying. So there's obviously a strong movement, and I know definitely in South Africa, some of our big organizations, our South African Medical Association and even our Health Professionals Council has come out against medical assistance in dying because they feel that it is the ultimate aim of any medical professional to safeguard life. But then I think they do neglect, quality of life considerations and so on, but there is still this focus on that. And I think a lot of times strong things like cultural values, religious values and so on comes into play in these arguments. But yes, we have to always consider that when we deal with these things. Then there's obviously the concern that if you have something like a serious mental illness, that the illness is causing the request for the assistance to die, that it's actually just a suicidal wish that's being expressed. So that is, I think, something that is very difficult, and especially for me not having expertise or dealing with these types of requests, I think it would be nice to hear from the experts what their opinion is about how to distinguish between a rational request for assistance in dying versus a suicidal thought. Then we don't want to reinforce helplessness. I already discussed the impaired decision making, which is always a concern in these cases. But I think especially in our psychiatric patients, there's always the concern about potential for undue influence from external factors, either the family or them just not having access to care, or them feeling like a burden and then asking to die because they don't want to put that pressure on society or on their families. The other thing that is a concern with serious mental illness is the definition of the irremediability. When do we really say that there's absolutely nothing that can be done anymore? I think there's so many different combinations of medications, other interventions, different forms of psychotherapy that can be combined with medication, that it is difficult to get to that point where we say this is really the only thing that we can do. But I think if you work in psychiatry, you all know that you have dealt with that patient where you've tried everything that you could think of. You've consulted with colleagues. You've tried every possible combination that's available and affordable, obviously. But it also might be difficult depending on side effects. So I think we do know that we do sometimes reach that stage where we just have to say, this is what I can offer, and there's really not much more that can be done. But there's no clear cutoff and there's no clear definition. And then there's always this slippery slope argument where people come with that idea of, if you allow it now for people with mental illness, the next thing will be that you're going to kill all the poor people, basically, that type of argument. So we must always just be prepared to discuss that with them and to come with the arguments that shows that that is not really a concern if the laws are in place and people are behaving in an ethical and legal manner. But then in support, I think, obviously, once again, and, some of these are very similar concepts that can be used on both sides. So I think, once again, the autonomy, the individual and so on is at the forefront. So it is that if you are an individual who's self-aware, some cultures and societies might feel that that's not the most important. But I think, for us in the medical profession, I will feel very uncomfortable to do anything to a patient just based on somebody else's opinion. So I would still want the person as an individual to at least assent if it's somebody who does not have decision-making capacity. But it is difficult. I know we treat people involuntarily, but then it is because of the risk that they're posing to themselves, not because of somebody else's wishes. For me, a very, very strong argument is obviously the unbearable suffering. I think working as a psychiatrist for many years, I know, and I've seen patients suffer, that it is not really any less than a patient with cancer who's busy dying, and it can then in many cases actually be more protracted and chronic, which can be very difficult to observe if there is really not much more that can be done for that individual. If, like I mentioned earlier, all the options have already been attempted, or if it's just somebody who can't use a lot of the options that's available due to potential side effects or contraindications. Another thing is that I think that the people who's really against medical assistance in dying really makes a big thing about the difference between an active act and, versus withdrawing or withholding treatment. But if you really think about it and you read the arguments around these, there's really no moral difference. In the end, the outcome is the same. If it's just a passive type of thing of not giving a treatment, or if you actually give the patient a medication that gives them the route to end their life, the moral outcome is really not distinguishable. Yes, and I think then once again, just the personal freedom of the individual, adhering to the legal criteria. If we follow the criteria, then there's usually not a concern for that slippery slope argument. And then also a strong argument is that if a patient is then asking for assistance to die, even if it is a suicidal type of idea, we can't abandon them. We must still assist them and help them and facilitate a possible dignified death if that is then the outcome that is desired. Something that we have to consider, though, are obviously the external contributing factors. So especially in the philosophy schools and the things that I read, the whole movement and focus to externalism is quite prominent there. And I think as working in psychiatry, most people will know that, yes, there's obviously definitely things, poverty, nutritional factors, just access to care, all those types of dynamics plays a role in the consistence or the persistence of the illness or the symptoms that the patient might experience. But we also know that that's not always the only thing. There is definitely the strong biological component. And, in some patients, you can address all these external factors, but the symptoms will not necessarily subside. So it is very important to consider all these things, but we can't just look at the external things. We must look at the individual and keep them in mind in all our assessments and evaluations. A problem is, and especially in a country like South Africa, we have a lot of inequality in terms of our access to care, our social environments, our wealth disparities in the country is really significant. And there's a very big portion of people who's very, very extreme poverty and unemployment. And I think in Europe, that there's all these challenges with forced migration, how to integrate those people into existing systems, political instabilities that are really, if you look at the news or read anything, it looks as if it is spreading quite widely, and there's no country that's really very stable. And then on top of that, there's obviously other challenges like environmental challenges, climate change, all the traumas and displacements that comes with that. So I think we must just always keep in mind that when we have these requests and these assessments, that we must not just consider the desire to die as the lack of support, but because of the lack of support. So we must make sure that there's really underlying causes or reasons for that that we can implement made. Otherwise, we are really going to basically allow people who's just at the very, very end of the spectrum in terms of socioeconomic privileges, that they can basically end their hardships by these types of requests. And as a country, I think the political will must be there to really alleviate those pressures. Now, in South Africa, like I mentioned, we don't really have any legislation about it. So I've obviously looked at a lot of international literature, and the American Psychiatric Association is very against this. But I know that certain states in America is more lenient towards MAID for mental disorders, or definitely for terminal conditions. But the Psychiatric Association says that no psychiatrist should prescribe or administer the intervention to a non-terminally ill patient. So that is, they very strongly against it, but I think there's much more to consider when we take these things into account. And I think, like I mentioned earlier on, the excruciating pain and the suffering of the patient can definitely be a consideration where I think we can't just leave it for other medical professionals. Psychiatrists and mental health professionals have to be involved with these assessments, and sometimes then even with the administration of MAID. However, we must ensure that we do not become, we don't sort of endorse suicide. We must make sure that we still remain optimistic. We try and instill hope. And this is where there's then, like with most forensic type of assessment, where there is the split between the therapeutic practitioner and the legal or the medico-legal assessment. So I think it is extremely difficult if you have a therapeutic relationship with a patient requesting MAID to be very objective in your assessment, to look at their decision making and so on. And that is where I think it's extremely important, and most of the legislation allows then for different opinions, and then definitely for independent opinion where it's not somebody who's therapeutically linked to the patient. And I think that is where we then safeguard the person, but also the therapeutic doctor or psychiatrist, that you don't transgress boundaries because you really just want to help your patient at all cost. And I think the palliative approach, we all know that it is mainly focused on preserving quality of life and not extending life. And that is always something to consider. Now, there's definitely people who has this idea, and I've been in talks or discussions where people will say, no, but countries where there is access to MAID, there's no palliative care. And that is obviously just not true. That is a very broad generalization. And if you look at the literature, that is really just not in any way true, basically. So these two things can be used complementary. And I think they should be used complementary, where you can actually implement all the palliative principles of preserving quality of life, looking at the spiritual and symptom relief, psychosocial support and so on, but at the same time doing the MAID evaluations, looking at the patient's capacity and, if they really qualify for this or not. And I think just important, even in countries where there's no access to MAID, we then obviously have to implement these palliative principles, and not just for patients with terminal illnesses, obviously for people with serious mental illnesses, this is an important consideration. The thing that I always appreciate of the palliative approach is the focus on the patient's values and their preferences. But then this is where obviously if the patient then wants assistance in dying, that is their preference, and that must be really taken very seriously and not just be dismissed. Now, in a country like ours, where it will obviously be illegal, and you can be charged with homicide if you do implement that. But in those cases, then at least not adding on to the burden with unnecessary futile interventions that will prolong life unnecessarily. But that balance is very difficult and important to have. And I think it's just important for us as the practitioners to really educate the patient about the options and potential outcomes, but as always, in very clear, understandable terms. These concepts can sometimes be very difficult, and especially if you're in a country where health literacy is not great, then I think, you must really make it very simple for the person to understand what they are asking and what their options are, other treatment options that can maybe be tried first. But it's also important for this to be a two-way street, and for us to then really listen intently and to consider the values of the person and what they really want. And this is really just a slide to show the complexity of these things and how it is impossible for us as individuals to deal with this on our own. I think in psychiatry, with most of the conditions being so multifactorial and complex and all the other psychosocial aspects that come in, you always have to have your multidisciplinary team to help with the family relationships and their expectations as well, because especially in scenarios where you have an individual requesting made, but the family is completely against it, that can cause a lot of problems and potential legal challenges. So that is where the family must be brought into the discussion as well. And then certain cultural aspects will have to be considered there. And in a country like South Africa, we have a very, very multicultural society. So we then sometimes have to get people in from that specific society to explain and to assist with these types of discussions, because there's very diverse views and very diverse opinions about these things. I think in the end, it is really about having a holistic view, having all these things that you cover. You must look at the comfort of the patient, look at their nutrition, if there's wound care or anything like that that needs to be in place. But then the disease itself, you know, and we know that with the serious mental illness, there can be all these other comorbidities, but all the terrible side effects that these patients might be experiencing as well. And if you consider these serious mental illnesses, many of these patients might be on medications like clozapine, for example, with the constipation and all those types of things, or other medications with a lot of anticholinergic side effects. So all these things must be addressed. And then if you consider the palliative approach, there's definitely a move towards minimizing the amount of treatment, you know, anything that is not just for symptom management and keeping the patient comfortable. You must then try and get rid of all those things. But the psychologist must be involved, social worker, occupational therapist can obviously implement certain measures as well. And then if it is the patient's preference, spiritual guidance or religious practitioners can also be consulted. So yes, I think I've said this more than once now, that I think it must be a focus on the alleviation of suffering and the quality of life of the patient. And it is really not easy to make that call, that to say that this is now really a condition that nothing can be done for anymore. And that is where some of the legislation, like I mentioned earlier, is in a bit of a, you know, it causes a little bit of a controversy about patients refusing treatment. But I think, once again, we must respect their decisions unless it is something where they are acutely psychotic and suicidal, and then we must treat first, but then in the end, if they then still decide that they don't want any further intervention and they have the capacity to make that decision, we have to respect that. So it's this dual track approach that can sometimes be a very difficult balance. And that is where I think it helps to get the multidisciplinary team or other physicians or psychiatrists involved to help, where one will really be focused on the therapeutic aspect, instilling hope, trying to address any suicidal thoughts, while the made request is really also being seriously considered, and the patient is being reassured that if they do qualify for it, this will be an option for them. Access to care, I think in most countries, I've read a bit about, you know, even countries like the UK, where they have the national health system and so on. With those countries, there's also challenges. It's really a lot of related to things that I mentioned earlier, you know, the migration, political instability, financial challenges, and so on. So we must just make sure that at least a patient had the option of other care before they then access MAID. But it will depend on their preference, obviously. But, you know, we must just make sure that just because they're in a rural area, for example, that MAID won't be the first option that is provided to them. And this is where we really need our governments to be much more involved, and other organizations like our medical organizations and so on. But there's not always the political will for these things. And especially in our country, geriatrics is usually at the end tail of all the services and all the budgets and so on. So there's so many other things, childcare, all our HIV challenges and so on, that geriatrics usually do not feature very high up on the list. And we really trying hard to be advocate for our patients. And that is where I think we must just be the voice of our patients, where they might really not have the necessary care. But mental health is an essential human right, and we must ensure that every individual that needs access to care can actually get it. That they, even if it's not medication, if it's just therapy, that there can even be something like online digital therapy at this stage. That is an option if it's somebody very rural, but we must make sure that they do have these options available. And then also, even though we want to advocate for them to have the access to the care that they want, we must also make sure that if they are very vulnerable, if they're acutely ill, if they don't have decision-making capacity, that we are not actually implementing things that should not be done and infringing on their rights in that way. So it can then be seen as a form of neglect. So we must make sure that that is not the case. And we must also then confront all these challenges. So it's obviously we will have to work with public health specialists, all these societal challenges that is undermining mental health of our society at the moment, that we can see what can be done to improve those types of aspects as well. And then I think I want to end with two questions, and I think this is specifically for me of interest, having experts here today who's been working in this field and might have actual experience with this. The specific cases or examples where you felt that a patient was really well enough in terms of their medical or mental condition being well controlled, but that is still the reason for them to get the assistance in dying. For me, that is just not having practical clinical experience. That is for me difficult to understand, because, if you are so ill that you qualify not to or to get made, how can you then say that they have that decision-making capacity? So it will be very interesting if somebody can give us some practical examples of that, and then the circumstances where it is considered appropriate for psychiatric aid in the absence of any other life-threatening conditions. Thank you.
Thank you very much for this presentation. I would like to give the floor first to the audience. Does somebody have a question for Carla? Maybe you can raise hands so that's most easy for me to see. No, I myself. Oh, I see Radboud having a question. Please.
Yeah, thank you, Carla, for this very excellent presentation and overview. I have a question about your country, about South Africa. There's no legislation for MAID, and you're telling us about palliative care for people with a psychiatric disorder. And also, yeah, I think worldwide, also in the Netherlands, it's quite difficult. And we are in the beginning of implementing palliative care for psychiatric reasons. So I'm curious, how is the palliative care implemented in South Africa? Because also, not only mental health, but also palliative care, in fact, is a human right. So it's very difficult if the palliative care is not implemented very well to talk about euthanasia. Can you tell me something about your country, how you deal with palliative care if there's no legislation for euthanasia?
Yes, it is very challenging, and I think we do not have a lot of services. The services are very fragmented in our country. So we don't have easy access to palliative care in a psychiatric hospital like where I am based. It's a tertiary psychiatric hospital. unless there's somebody with an interest in it, like I have an interest in it, so I will then try and arrange, but for example, for us to get opioids for a patient if they have a terminal condition, or if it is somebody with a condition like one of the dementias, the neurocognitive disorders, then I will definitely start discussing things with if the patient still has the capacity, which in most cases they don't, because we unfortunately see them usually when the illness has progressed quite far already. But then to start the discussion with the family about not implementing unnecessary interventions like inserting PEG tubes and antibiotics and all those types of things that will then, obviously prolong their life, but also their suffering. Unfortunately, because services are so fragmented, what then happens is if you're not on duty and you come back, then you see, oh, but the patient's been put on antibiotics again, even though it was stated that they should not be. So it is really a challenge. But even for psychiatric conditions, where we know that some patients just don't benefit that much from the medication. So we have quite a lot of patients on those, treatment-resistant schizophrenia on clozapine, but the clozapine is not really making a significant difference. Then I tell my registrars, please, let's minimize the treatment. Let's see what we can get rid of, because if it's not taking the hallucinations or the delusions away, why do we want to keep them on these medications that's just going to burden, cause side effect burden and things like that? But it is really not easy. Our legislation basically makes provision only for terminal conditions for withholding and withdrawing of treatment. But other than that, we don't have, not even things like advanced care directives or living wills have good legal backing in our country. So it's really a bit of, you do what you think is the best for the patient in most situations.
Thank you.
Okay, thank you.
Yeah. I've also a question, because I've been thinking about if you look at the low and middle income countries and made for psychiatric disorders, it is often stated that, well, if people don't have good access to mental health care, it can be a solution for social disadvantaged groups, and they maybe get more easy made or for social problems. But if you look at the data from the countries in which it is allowed, like Canada, Netherlands, and Belgium, you see an overrepresentation of high educated and high income groups, native born population, people with a strong health system literacy who have good access to specialist care. And especially the marginalized groups of the socially disadvantaged groups, they hardly are represented in MAID statistics. And so I think the same could count in low income countries. And do you think you should fear about it, that it would be used for social problems?
I think what we see here, even though we don't have it available, but is exactly as you explained, that usually the people in our more rural areas with more traditional type of belief systems, and usually, unfortunately, socioeconomically less well off, they are the groups that feel very strongly that, these types of things are not things that I want to talk about even. They don't even want to talk about things like advanced care directives.
Yeah.
They have a very strong cultural belief still in many areas about ancestors, that they have to live their life to completion to join their ancestors, and any medical intervention will actually be against that, especially if the intervention then hastens their death. And the cases that we've had in our country, that there's been some, isolated legal cases where people did ask for this. It's always been socioeconomically well off, very educated people, everybody with tertiary education and those types of levels. So it's definitely more that type of profile of people who's requesting and who's wanting to have it here. And I think it should not be something that will just be used to get rid of people that you don't want in society, because in the end it will be up to them to come and request it. And I think it will definitely be more educated people.
I think it also, we need to go to the second part, but I was also thinking,
sorry, Richard, because Sorry, Donna has a question, but
Oh, sorry, I didn't see it. I don't see a
Donna
hand.
Stewart. Sorry.
I didn't see your hand. I'm very sorry. Donna, take the floor, please.
Okay.
Yes, Carla, thank you very much for that lovely overview of MAID for mental illness. I work in Canada, and you may know that our government commissioned an expert panel to look at this issue and published a report, which I hope you have access to. The other thing I wanted to mention is that just yesterday, the Canadian Association of MAID Assessors and Providers has started its own journal. And the first publication of the journal came out yesterday. So I wonder if we could perhaps start a library of some of the resources that we have from other countries, which might be quite useful. And then finally, I wanted to just comment on the involvement of families, which in general, I think is really, really important. But I think we have to recognize that sometimes patients do not want their families involved. And this presents a dilemma for MAID in general, but also for MAID for psychiatric patients. And maybe, Carla, you could address the issue of what one does when a patient very clearly says, I do not want my family involved. We've been estranged for many years, and I do not even want them to know that I'm asking for MAID. Thank you.
Thanks. Yeah, I think, that is a very difficult one. And we also always try and encourage our patients to get the family involved. But like you mentioned, I think in many of our patients, we know that there's estrangement. Basically, a lot of our patients were dumped in the hospital, to put it that way. The family just do not want any involvement with them anymore. I think for me, the main consideration would be then the confidentiality and the right of the patient. And unless they give permission for us to divulge this information to the family, there's not much that we can do. So I think it's trying to talk to them and to convince them. But in the end, if they don't want to, it is up to them to make that decision. And I think if you then discuss it with the family, you will be in breach of confidentiality.
I agree.
Yeah.
Thank you very much. I'm just looking for hands. I have to scroll my screen, but I don't see any hands. So Carla, I thank you very much for your wonderful talk and discussion. And we'll go to the next speaker, and it will be an interview between Radboud Marijnissen, the president of IAADM and a psychiatrist, and Lieke Haas, who is an expert by experience. And what it exactly is, I think they will tell that in the interview. So I would like to give you the floor, Radboud and Lieke.
Yeah, thank you, Richard. Lieke, are you there, or I haven't seen you
Yes,
yet?
I am.
Oh, that's great. That's great. Now, in the next part of the webinar, we'll be hearing a personal story from an expert by experience. That's Lieke Haas, who has gone through, or in fact, is in the middle of the process of requesting euthanasia on psychiatric grounds. And the conversations aim not to debate the issue, but to listen and learn from your lived experience. And I know Lieke Haas quite a bit, and I know that she's open for questions from the audience later on. And first of all, I want to thank you, Lieke, for your willingness to share your personal, sensitive story with us today. And please feel free to share only what you are comfortable with. And if at any point you'd like to pause or skip a question, that's completely fine with me. And you say that please to me. And our goal is to listen and learn from your perspective. We'll have an interview, and afterwards the audience is free to ask the questions to you. Is it okay, Lieke?
Yes,
Yeah.
of course.
Okay, great. To start off, could you please tell us something about yourself, introduce yourself, tell something about your background?
Yeah, of course. My name is Lieke. I am 35 years old and I live in the Netherlands, near Amsterdam. In my daily life, I do a lot of volunteering, mainly as an expert by experience, but also in my neighborhood. In the past, about myself, in the past I did a lot of classical ballet. Unfortunately, due to my physical health, that's no longer possible. But I started singing almost 1 year and a half ago, I think. And currently I mainly sing oratorios because of Christmas. But my passion lies with opera. I have been suffering with mental health issues since I was 10, I think. It started with an eating disorder and that continues to this day. Treatment had mainly been focused on the eating disorder, but I think 6 years ago we decided that treating the eating disorder wasn't effective anymore, and that I really needed to start working at the background of my eating disorder, and that is complex PTSD with dissociative symptoms. I think that's about me.
Yeah. That's quite a lot you're telling us. We'll come back that to later point in this interview. But you're telling me, and I know you as an expert by experience, you're telling you're working a lot as expert by experience in different organizations. Could you tell me something about that? Could you tell us something about that, what you're doing, what motivates you in that role?
Yeah, my work as an expert by experience is very diverse. For example, I act as a sounding board for various studies being conducted in this field in the Netherlands. I've also spoken with various client councils of large mental health institutions. This was partly to hear how the subject is perceived within the institutions, but also with the aim of a little bit removing this taboo surrounding the subject. And finally, I spoke at a conference about euthanasia in case of mental suffering. And I'm also happy to talk to individual psychiatrists or other mental health professionals when they have questions about subjects. And the thing that motivates me is that I think especially in this field, it is very important to listen to the people who are in the process or are thinking about these kind of questions, like asking for MAID, because I think when that you only can learn from people when they're still able to really discuss. I think that there are still that they need still to be. I can't come up with the word. That they didn't. That there should be more in their life than only the request of MAID, because when they're in the process, I think it will be too difficult to talk about it a lot with a lot of other professionals than your own team.
Yeah, I understand that. Yeah, and you're working as an expert by experience also in the committee Euthanasia of the Dutch Psychiatric Association. I'm the chair of it, of that committee. And in this committee, we think it's very, very important to have the voice of expert by experiences, because it motivates us to have the broad care for the people with specific wishes to die. Can you tell me something about that, about your work there, Lieke?
Yeah.
About your work in the committee.
Yeah, mainly I offer my perspective from my own view, but also with the view I've heard from a lot of clients which I spoke, which have requested or are going to request MAID. And so I'm trying to give a broader perspective of the client perspective in this committee, because most of the members are mental health care professionals, and I think it's very important that there's also a sound from the patients, which whom this is about. So
yeah, it's quite a different or perspective. It's very useful. Yeah, and your perspective is also based on your own on your own complaints about persistent wishes to die. In fact, I have to say persistent wishing is not to live with all those complaints. You can you tell me something about it? Can you share something about your personal experiences to consider euthanasia as an option? Can you tell something about the context in which the euthanasia request had developed in your case?
Yeah, I personally didn't thought I would ever come to the point that I would request made, but the reason I started thinking about euthanasia was after yet another treatment was discontinued because it wasn't effective. Although I've never experienced depression, the struggle was becoming more increasingly difficult, and moreover, it was becoming increasingly difficult to find treatment. I think in case most patients, they really don't want to die. They don't have a wish to die, but they, just as they don't. They want an end to this suffering. And I would prefer myself to achieve this through treatment, but that's currently not possible because no suitable treatment can be found at the moment. And I don't think that there will be another treatment found due to the complexity of my condition. In addition to my mental health issues, I also struggle with many physical complaints, and these were ultimately the final straw that led me to request euthanasia. My days actually often consist literally of surviving myself and no longer of living. And when I realized that, I started thinking about, do I really want to continue this for another 10 or 20 years, or do I want to consider that there's also a possibility to end this suffering?
Yeah, because in your case, I understand the suffering is unbearable for you.
Yeah, at the moment, life as it is now with my mental and physical problems, it is. It's.
Yeah. And can you tell us what makes the suffering unbearable? Why is it unbearable for you?
I think because of the vicious loop I'm in. It's my day starts with a lot of physical complaints, and these will take a lot of time. So I'm not able to do a lot on a day because of the physical complaints, but they also increase my mental health condition, and because of my PTSD, I don't get a lot of sleep, so I'm not able to rest from the complaints during the day. They will go on through the night, and the next morning it starts again, and without any pause, without any vacation, or and this has been like this, I think, for almost 25 years. So without any without it becoming lighter or less.
No, there was no improvement.
No,
actually,
I think I've learned some really good things in therapy, but I've also learned a lot of things which didn't help me. And I've also tried for a period to stop treatment because maybe I thought that was the solution. But that my complaints are just too difficult to live with. So I need some treatment, but I've had a lot of clinical treatment, and I think that didn't help very much. I've had a lot of I've learned a lot from my individual treatment, but not from the group therapy I had.
Yeah. Okay. And so I understand you're suffering unbearable for many years. There's no that you are saying there's no treatment for me anymore to improve the unbearable suffering. And at which stage did you decide, or did you decide that you talked with somebody else about your euthanasia request? What has been the process of the trajectory like for you so far? At what point are you now in the process?
Yeah, I submitted my request to the exercise center. I don't know if everyone knows what it is, but in Holland we have a center where you can request euthanasia, and they are specialized in mostly in physical, in case of euthanasia in when a patient is terminal, but they also have some psychiatrists, and they will do the applications for in case of mental suffering. And I did my request, I think, almost 3 years ago. It was initially rejected because there was supposedly still a treatment option available. And unfortunately, this also proved impossible. I've now had my first meeting with the expertise center, and
sorry, Lieke, because sorry,
No?
you're saying you requested the euthanasia in the expertise center euthanasia in the Netherlands, eh?
Yeah.
But you didn't request for euthanasia your own psychiatrist. Why did you go to the expertise center?
Yeah, I did it. I also did it with my own at my own psychiatrist, but because I don't use a lot of medication, or I don't use any medication, I don't see the psychiatrist very often, so I don't have a very close bond with my psychiatrist. So, and for her, it was the first time she had had a request, and she was, she understood it, but she had very much a lot of trouble to reconcile, because she knows I have a very strong desire to live, but she also knows that I have that my suffering is unbearable, and she really wants me to go to another treatment, but she also knows there's no option anymore. But for her it was ethically too difficult, and that's why I decided to do the request at the expertise center, because there is a broader team to look at my request. So
okay, so in the first time it was rejected, and why was your request rejected? Can you tell me about that?
Because at that point 3 years ago, there was supposedly still a treatment option available, and when I wanted to try this treatment, it seemed that it was proven not to be an option anymore, because they only treated PTSD and not with the dissociative symptoms. So I couldn't start the treatment at all.
And what kind of treatment was that? What kind of treatment was proposed?
A clinical treatment. I think it was 3 months internally. It was 3 months in a hospital, and after that, you would go back to your own
treatments.
And
so it was a clinical treatment focused on the PTSD.
But it was with, I think, EMDR and exposure therapy, and both of them hadn't proven to be effective for me in the years which has already passed. So, and because of the dissociative symptoms, they only treated PTSD as a as a solid disease, so not with a lot of
So it was not the treatment that could improve the unbearable suffering.
No, and the treatment center itself decided that they didn't want to treat me because they weren't specialized in dissociative symptoms. So before I even could start, they already pulled out they already withdrawn themselves. So
And how was that for you? Because you are telling us that you have a very strong wish to live, but you don't want to live with this unbearable suffering. How was it that it was advised to follow the treatment, and that was it a disappointment, or how was it for you?
In the beginning it was, because I already had some skepticism about treatment, because I thought I've already done a lot of these things and they didn't prove to be. So in the beginning, but because I really would like to live without the suffering, I would be open to try. But if I'm not open to try anymore to a treatment, if I'm not open for a treatment anymore when it's only causing more harm. And I thought it would cause more harm because they would at first they would increase my fears and my and the chance that it would be effective with the treatment to lower the symptoms would be very small, because in the years before it hasn't proven to do so. So and after that I still tried with my own psychologist to still treat the symptoms, and I think we've tried for almost 2 years after that. And last summer she decided it wasn't effective, so she really needed to stop, and that was a real big disappointment because I really wanted to go on. But she
said it was not worth to go on.
No, she really thought it would be worth, but she saw it really was causing me only harm, and it didn't improve anything. So and I'm very I have a lot of willpower, I think, but she couldn't see, she couldn't look at me anymore and see me only more suffering than then becoming better.
And do you agree with that? Do you agree with her opinion?
Yeah, I agreed with her, but I still thought it also scared me, because I thought, and then what do I need to do now?
I understand. Yeah. So at what point are you now in that process, the process of the request of the euthanasia?
I have had my first meeting with the expertise center a few weeks ago, and it was decided that I will be assigned a team with whom I can really investigate my request.
So they decided to investigate your request if the due care criteria are met.
Yeah.
And how was that for you, that the decision that they will assess that point?
And I think my case is maybe a little bit different than for most people. I wasn't relieved or something like that. I got scared, but there was a little bit of relief, but also a lot of fear, because I still hope that there will be a treatment, but the chances are really small. And I think the most hard thing for me was to see my mom. For me, also the most hard thing in the process was to tell my mom that I had submitted the request, and she was with me when I went to the meeting, and seeing her cry, and realizing that there would be a chance that she would lose her child. I think that's the most painful thing to see. I really love her dearly, and I think the most hard thing for me when I would undergo euthanasia would be having to let her go, because I think that's the most
to leave her.
I think that's the most painful thing of all, that you have to leave that what you have to leave behind, the people you love. And because I don't find death or dying particularly frightening, maybe perhaps of my faith, but having to let go the people you love is the most painful thing of all. I think also, without any mental health issues, I think everyone can understand that.
I understand that, and I think it's quite difficult, because on one hand you want to stop the unbearable suffering, and on the other hand you don't. It's very difficult to leave the people you love.
And
I understand that. Yeah.
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 And
So
I've
that
also
was a very sorry. Yeah.
yeah. I also had a lot of trouble with making decision for myself because of that, because I'm still wondering and keep asking myself the question: have I suffered enough, or or am I still able to keep on going with this suffering? For me, also, it's still a question, and I'm very glad.
And how will you come to an answer? That's a very difficult question.
Yeah.
Question: have I suffered enough? Yeah.
Yeah, and I think that that for me it will help to discuss this with people who have had a lot of experience with this. And that's why I also find it very, I think, comforting that it will be a broader team. So I will get a doctor and a nurse, which are going to come to my home and also talk to my family. So I think, I hope I will come to an answer, and maybe I will not come to an answer. And I think that will, in that case, I will not get euthanasia, and then I have to bear this suffering longer until maybe I come to an answer at some point, and maybe not. But yeah.
And it's quite difficult because yesterday, you're suffering unbearable, but you also take decisions about your personal life, about you've moved to another house, which you enjoyed in your house. So that's a lot of decision you are making nowadays.
Yeah, and also because of I'm still keeping the option open that I really that there hopefully is a life for me in this life, and but if there will not change anything in my mental or physical condition, I don't think that I will that I'm able to go on for another 10 years. And maybe
10 years. Yeah.
No, but also not for 5 years, I think. There really needs to change something. But in case there will not be I'm not convinced enough of me wanting to die. A new house is very welcome, because my house is I don't have, so living in those two in those on those two sides it's very difficult, also for me, but also for my mom and my brothers. So yeah.
And can you have told us something about your reaction of your mother and your family? Can you tell me something about the reaction you've received from the healthcare professionals, or your psychiatrist or your psychologist or other ones?
Yeah, my family and those closest to me reacted very understanding, and I only have a very small network around me. It consists mainly of my mom, my two brothers, and my sisters-in-law and my two nieces. I don't speak to my dad very often, but also he understands. And in the healthcare system, I had some more. I think I had a little bit more resistance, because for them it was really difficult because of the fact that I really wanted to live, and they only see me 1 hour a week or 2 hours a week. They don't see the whole the whole picture of of how much I suffer in a day. But they understood, but I would prefer for me to undergo another treatment. But in the end, they also had to include that there really was no other option. So in the end, they reconciled. But in church, I had a lot of resistance, and that started when I first mentioned something about it, and that was, I think, almost 3 years ago. And after that, I also decided to stop going to church, because a lot of people told me that if I would pray enough, that my suffering would come to an end, and if I would maybe I was a sinner because I had so much suffering, and it didn't help. I'm still a practicing Christian, but I I do it from my own home, so not in a church anymore.
Yeah. So I'm asking myself, the question, did I suffer enough? Was it also caused by your religion, or is it caused by your personal believing?
I think a little bit because of my religion, but I don't believe in the way that we have to suffer to gain access to heaven or something. I really believe in a loving God, so I think that me suffering, I hope that me suffering is causing him a lot of grief. So I don't think that I also don't think that he has planned for me to come to this stage. So
I understand that.
Yeah.
Okay, but you said you stopped going to church a few years ago, so I can understand you also lost a lot of contacts then from the church, or not? Or are you still in contact with the people from the church?
No, unfortunately not. And when people hear you go to church, they think you have a real broad social network around you, and that when you're ill, that you will have 10 fruit baskets at the front door or something like that. It's for me.
At least they will support you.
Yeah.
With fruit baskets.
Yeah.
Or brownies or nothing. I understand that. Yeah.
But in my case, I haven't had a lot of support. Actually, I think from the point they knew that I was suffering with mental problems, they were more. They already were a little bit avoided me because they really didn't know what to do with it, and when there were reactions, that also was, but you have to pray more, or you have to you're in, of course, you sinned too much, and you don't believe enough, and those questions for me were very difficult because my family aren't believers, so I was already on my own in my own network, but at the moment I don't have anyone to share this with, and that's sometimes is, especially around Christmas, is very alone, I think.
And but do you have any contact with, for example, a spiritual caregiver or something? From the mental health institution or something?
I have had in the past, but the person who I spoke with, I didn't click with. So I think it's also very important to have a personal click with someone, and I didn't have that with that person. So
that's clear. Okay, Lieke, looking back, what would you like to give the professionals to better understand about people in your situation and people with requests for euthanasia or request not to live with the unbearable suffering?
I think
do you have any advice?
I think the most important thing I try to convey when I talk about this subject is that I believe only a very small percentage of the people apply because they really want to die. I think everyone wants to live in some sort of way, but much more often it's about ending of the suffering. I think that's really important to realize. And many often and often after after years of struggle. And I think the most valuable thing that those around them can do, both professionals as loved ones, I think, is to stand by their side and discuss it openly. I've often seen that acknowledging the suffering has helped people to find their way back to life. And I think in this case, talking can really save life. But when I also think that when even talking no longer helps, that a little bit of respect to the choice of these patients, that there really is no other option to die, however bitter and sadder this may be, is also a possibility. So Yeah.
Okay, that's very, very, very clear. Well, because of the time, I think it's good to see the audience. But thank you, Lieke, for sharing this story. It's offers an important insight. But I want to see if there are any questions in the audience for you. I cannot see it.
I don't see any hands at this moment.
We see one hand, Kenneth and Martje. Yeah, Kenneth.
Yes, Lieke, thank you for that testimony and giving us some really good insight into the life world of someone with this request. It's very powerful. So thank you very much. I learn a lot every time we hear these stories. Just one question to you. There's also a lot of discussion about to what extent is a made request actually, how do you say it? How close is it to the idea of suicide, right? So to what extent does that play on your mind as well? To what extent, I mean, what is the relationship between your requests, but your wish to die, and there's different ways to go about it, and made, how do you see a request for euthanasia in relation to a suicide ideation or anything in that direction?
Yeah.
For me, suicide and euthanasia are really two different things, because I haven't had a lot of suicidal thoughts, so I'm not the person maybe to ask. But when I think about suicide, I think it's very it's more of an impulsive and more of an impulsive idea, and also which is from it's more in the moment, I think, and euthanasia request is more thought over for many years. I think for me it has taken 3 years to make the request only. So before thinking about it, it took 3 years without any suicidal attempts. So I think that it can be two really different things, but I also know a lot of people who have a lot of suicidal thoughts and also have a euthanasia request. So
it's also an answer to the question of Carla earlier in her presentation. So for you, for the patient with a persistent death wishes, it's quite clear to differentiate between suicidal thoughts and the euthanasia request in your case, at least. Yeah. It's okay, Kenneth, about this? Oh, sorry, Richard, you're the chair. Sorry.
Yeah, I'm not Martje, you had a different second question.
Yes, it wasn't really a question. I just wanted to thank you a lot for your, as Kenneth said, testimonial. Normally I work with elderly people with a lot of livelihood of treatments and psychiatric problems, and for them death is not so far away. But the way you were talking about it, I could really see the struggle with, sorry, I'm also on call. Well, not right now. I can see the struggle for you with wanting to live, but not being able to live like this. For me, it's a new aspect because, well, like I said, I usually work with older people. There's a different dynamics. So thank you so much for
you're welcome
giving me this insight. Okay.
Thank you, Martje. Let me see. I lost Richard, but
yes, I'm back. I'm sorry. There's something happened with my connection. I'm apologizing.
Oh, okay.
Are there still any questions? Because I don't see all hands always, but I'm checking. No. I have one question myself for you, Lieke, if it's possible. You said you suffered a lot and unbearable, and it's very hard, I think, if you see it for all those years. And on the other hand, I hear some very important things for meaning in life, like your job as an as an how do you see it, expert by opinion,
Expert by experience.
For example, do you think that looking for meaning in life can ever make your suffering bearable? And why or why not?
Yeah, I think I do see a lot of meaning in my life. I don't think that and I really love doing what I'm doing. It still gives me a lot of energy, but I think that that in comparing I think with 5 years ago or something, like the energy I had to do those things was so much more than I have now, because the although I have a lot of meaning in life, it doesn't change my mental health issues. They will not improve because of it, and also not my physical problems. So I think but knowing that I have a lot of things I love, and not only my family but also a lot of things I do which I love, I know I have a lot to lose. So that also makes the decision very difficult.
Okay, yes, and thank you very much. I think it's very complex and decision and struggle also. And I was also wondering, because your thinking about MADE was about 5 years, you said, and 3 years ago you made your first action on it. If you would live in a country where it was not possible, what would that mean for you?
I also wondered. I was, I think, a few days ago, I was thinking about, what if I will not get in Holland? We call the green light after my my trajectory, and I think I don't think I will commit suicide, but I think that for me, I don't find death frightening, but I find the idea of the vacuum, or I don't know if that's the English word, but in which I will the suffering will become more and more unbearable, and having to live with it, that frightens me most of all. I think that perspective is the most scariest thing I can think about, because I think in the end I will become really I don't think I'm unhappy now. I'm also not happy, I think, but I'm not unhappy, but I think I will become unhappy and really unhappy. And I don't think I'm the person to commit suicide, but I don't know if in the end if I would become so desperate that I would commit suicide.
Okay.
Yeah.
Yes, thank you for answering so honestly. I'm thinking we are also reaching out of time, so I'm looking whether I can see somebody who likes to ask for last question. I don't see any hands. Then I will thank you very much, Lieke, for being so honest and open with us and to share your personal story, and Rapport for facilitating this. And I would like to thank all the audience for visiting this meeting, and I hope we can continue next year and grow a little bit and give more attention to this very sensitive and complex topic in all the countries worldwide. So I hope to see you next year, and wish you all the luck for the festivities in the upcoming weeks. And thank you very much.
Yeah, thank you.